Okay, so I'll just make a start and acknowledge that we are all, I believe, putting our feet on the lands that we now call Australia, but that represent the unceded lands of Aboriginal and Torres Strait Islander people from across this landmass and nation. And where I put my feet on the ground, that's the Whadjuk people of the Noongar Nation. And as everybody I think might know, I'm not from here originally, and it's been a real gift to me to find myself in a part of the world that has such a strong and continuing connection to land, culture, and country. And it has been a real privilege for me to think about what that means for me in our work. And I personally believe that Indigenous thinking can save the world, and that particularly when we think about the complexity of the experiences, but in these kind of health conditions, in this kind of health area, I think there's so much that we can learn from and adapt appropriately from Indigenous knowledge and wisdom as we go forward. So I'd acknowledge that this always was and always will be Aboriginal land. And as a lived experience-led and governed organisation, Health Consumers Council recognises too the importance and the contribution that people who share their lived experience in the spirit of improving the system for everyone, the contribution that that makes to the betterment of the health and well-being for the whole community. And acknowledge too that there can be a cost to that, and particularly in the space that is relating to weight, which is highly stigmatised. It's a real testament. I think we have to really honour the boldness and strengths of people who are willing to share their lived experiences in the willingness to make things better for all. I am delighted to welcome you all, and I know that more of you are joining to today's session. So welcome, the Well Collaborative. Many of you will know us. Tanya B, who's listed today as Health Consumers Council 2, is our digital engagement coordinator, and she is the one who does an amazing job at pulling together all of the content that you get now bi-monthly, as in every 2 weeks, because there's just too much content for making it monthly. And so we know that that's much appreciated. Because there's now a few more of us, I won't open up the microphones and ask for you to introduce yourself, but I would encourage you to please introduce yourself in the chat. Say, it's an invitation to share your perspective, what brings you to the Well Collaborative, and as much or as little about yourself as you would like. What I would ask is that we have somebody I know from the Health Department, HE32957. If you are willing to change your name to reflect your real name, then you're encouraged to do so. So I'm very excited to welcome you to today's conversation, and a huge thank you right up front to Mark Mellor and Alex Craven, who are both going to give a similar lens but a slightly different take on the question of the availability of treatments for a treatable condition that is obesity, and the availability or otherwise of those treatments in the public service, or accessible for people who may not, for example, be able to afford huge sums of money for either medication or treatment. I'm not going to say too much more about either Mark or Alex, other than to say that in my conversations with both of them, they have both been really strong advocates of lived experience perspectives, and also in advocating for better equity and more and a fairer access to treatment for those who seek it. What I will say up front is that while we are delighted to have the doctors who are treating us, for people who are here as consumers, this is obviously general information, and that we won't be able to get into specific questions about your particular health situations, but we hope that we would be able to help you make contact with people afterwards if you want to follow things up. So I will, like I say, invite you to say hello in the chat. Welcome to you all. And I'll start, we're going to hear first from Mark, who's going to tell us about his perspective as a GP, and then from Alex, who will tell us about his perspective as a bariatric surgeon, and then we'll open for discussion and questions. So, Mark, over to you.
Thank you, Claire. Thanks for the introduction, and thanks for inviting me to present. It's always a pleasure to talk about obesity, a condition that's close to my heart, being a child of lived experience and an adult of lived experience as well. I'm just going to share my, I'm not great with this, everyone, so if you just sort of bear with me a second. I got a new laptop and I need to share my presentation. Here we go. So hopefully, if I just put that into slideshow mode, you will all be able to see my presentation. Is that right? Can everyone see my presentation?
Yes, we can.
I have to double check these things. Okay, so I'm going to breeze through this this presentation, and I think everybody, there are different people in the audience, some clinicians, some not clinicians. So I'll try to sort of pitch it as best as I can. There will be time for Q&A at the end. So I think if there's any questions, any pertinent questions, then we can deal with those at the end. I can't see the chat, so I can't answer questions as I go along. But if Claire, if there are any burning issues, then I'm quite happy to answer them as we go along. So I'll leave that to the team to organise. So I'm going to talk about a couple of issues, and I think broadly the theme of today is obesity medical management. Just to introduce myself, my name is Mark. I'm a general practitioner with a special interest in obesity management. I'm based in Butler at Perth Weight Clinic, so that's up in the northern suburbs, and I also work in Netherlands on a Friday at Cardiometabolic Services, which is an obesity multidisciplinary obesity treatment service. So today, I'll cover a few topics. We shall talk about obesity as a disease, as a chronic disease process. I'll touch on some social narratives where we have been in terms of our understanding of obesity and where we're going. I will talk about weight bias and stigma, and then we'll have a conversation about obesity management medication. So I'll focus in on the pharmacology, the pharmaceuticals that we have that are TGA approved, therapeutics, therapeutic goods administration approved medication that is available here in Australia. And I'll touch on some of the things we can maybe look forward to, if that's the right word, on the pharmaceutical front. I'll then also touch on some advocacy that we've been driving around this. So those are my disclosures. I'm not receiving any honoraria or fee for today, but I have done speaking events and advisory board services for various pharmaceutical companies. And perhaps just to say as well, I will be touching on bias and stigma. And I think for some people in the audience, that could be quite confronting. And I recognize that. And the purpose of this is only really to highlight the importance of weight bias and stigma and how we really need to overcome it, at least not in healthcare settings, but certainly in wider society. So first, oh, hang on, what's happened? Where's my presentation gone? Let me go back to this, right, okay. So first of all, I'm just going to anchor us as to what obesity is. And I think, you know, the really key thing here as a clinician, and this is for all clinicians really, is really just understanding obesity as a chronic disease process. Weight is determined by a complex interconnected set of factors. It's largely beyond the choice of the individual, okay? And this is really, really important for people to understand. There are biological drivers, there are social determinants of health, there's environmental factors, and of course, issues around food industry and the way we've shifted from largely famine-based diets thousands and thousands of years ago. Well, actually, not even thousands of years ago, really just a few hundred years ago, but certainly from, you know, the evolution of Homo sapiens, we are evolved to live in famine. And we've got the genes, some of us more than others, that enable us to store that energy. So it's about survival, isn't it? Because famine has been the thing that's always threatened humanity. But now we've shifted towards modern diets, and there's many influences here. But I think the key message is that it's largely genetics that drives weight gain. But of course, we have environmental influences as well. And, maybe just to touch on a few of those, particularly around the social determinants of health. We don't really choose where we're born. We don't choose, in a sense, where we live. We are products of our environments in that way. And, what's provided is what's eaten. But more than that, access to healthcare, to certain foods, to activity, urbanization, exposure to environmental factors that can drive disruption, biological disruption, endocrine disruptors, which can cause problems for us in terms of energy storage, energy metabolism. So there are many, many, many influences. And I think the key factor is that it goes beyond the choice of the individual. Obesity is a whole body disease. So we can look at obesity through different lenses. We can sometimes be too focused as clinicians on weight. And actually, obesity is a whole body disease, and it can affect people in many different ways, both physically as well as mentally. And as clinicians, we really need to be thinking broadly about the person, making sure that when we approach obesity as a problem with patients in our clinics, that we're thinking about all of these different facets. Now, without perhaps going too clinical about things, one of the problems perhaps we've had for a very long time, really, since the original definition of obesity back in 1948 from the World Health Organization, which viewed obesity as a risk factor for disease, not as a disease in itself, is only recently have we actually gained another definition of obesity in the Lancet Commission. So the Lancet, which is a prestigious journal based over in America, they published a report earlier this year. They brought together experts, global experts, not just from medicine, but from across the board, from epidemiology, psychologists, dietitians, et cetera, et cetera. And they came up with two new categories of obesity, looking at obesity as either a preclinical disease or a preclinical obesity, or as a clinical disease process, what we now call clinical obesity. And I think it's a really helpful way of actually looking at obesity now. So rather than thinking about body mass index, waist circumference, and those sorts of things to define obesity, we really need to be looking at the health impairments that a person is living with. And clinical obesity describes those people that are living with a chronic, so long-term, systemic, in other words, it affects different parts of the body, illness. In other words, people are living not just with excess body fat that perhaps sits there and doesn't cause any problems, but it's actually driving these sorts of diseases. And these are the people that really do need treatment. If they want that treatment, they should have treatment available. And one of the big problems we have at the moment in Australia is inequity in access to treatment. So if we look at clinical obesity as being a disease process, why should those people not have funded access to treatment? If you're living with diabetes or cardiovascular disease, you have funded access to treatment for your disease. But if you are living with obesity, then that does not currently exist, except in small pockets where we do have some state-based funding for bariatric surgery, but we don't really have anything at all, pharmaceuticals, which are a really important part of treatment. Now, just turning to cultural narratives. For decades, the narrative has been that obesity is a choice. People can choose to eat less, exercise more, and that will resolve the obesity problem. And of course, we know that that doesn't work for people. The media buy into this narrative. So we get these stereotypical portrayals of people living with obesity, being lazy, gluttonous, unattractive, non-compliant, stupid, all of those sorts of things. And we see that play out even today. There is this locus of responsibility placed on the person living with obesity to get themselves out of that situation. And medicine has been great at blaming individuals, not just in the obesity space, but where we don't really understand a problem clinically, we're great at stigmatizing and blaming the individual for the problem. And we see this play out in obesity as well. So we've had these sort of eat less and exercise more mantras, one size fits all solution. And of course, Western ideologies of thin ideals and fat is bad. And all of this drives bias and stigma. How often do we see people in the media living with obesity portrayed in this way? Eating healthily, doing exercise, being active, living normal lives. Because people with obesity do all of these things. And it's a huge misconception that people with obesity only eat bad food and they don't do exercise. We've got Olympic silver medalists with obesity. So, we've got to really try and work hard to try and shift public and political and healthcare practitioner perceptions, but also the perception of the individual, because all of this drives internalized weight bias. The person living with obesity feels that they're responsible for it. They try and eat less, exercise more, lose some weight, can't sustain it, not because they failed, but because the treatment failed them. And then they blame themselves. And that leads to a whole host of downstream problems for that person. So we've got to see obesity as being separate from the person and manage it as a disease process in the same way that we manage every other disease. And over the last few years, the last decade, our clinical understanding of obesity has really unraveled. And we understand this now as a disease process, and perhaps not more so because we see how effective treatment is. If you actually treat people properly with effective and safe treatment, then you can actually treat obesity. So it's not a choice. And we need to really move away from those narratives. But unfortunately, they do still persist. Bias and stigma. So we use these two terms a lot. And what do they actually mean? I think it's helpful just to maybe clarify what these terms actually mean. I think we all can understand what they mean. It means sort of unfairness, inequity, those sorts of things. So bias is the sort of, it exists at the cognitive level. So it's how you think about somebody or a group of people. And stigma is the way you apply that ideology, that thought process to a person or a group of individuals. So bias is more active. Stigma is more active, whereas bias is the thought process. I think for all intents and purposes, it probably doesn't matter too much, except for the fact that we need to reduce weight bias and stigma. It's really, really important. But we know really clearly from evidence about the consequences of bias and stigma. It discourages health behaviors. People are less likely to engage in physical activity, less likely to go to the gym or go to the park and be active. We know that it leads to low self-esteem because people blame themselves, internalized weight stigma. This concept of allostasis, where people experience stress because of stigma, which actually drives unhealthy coping strategies, maladaptive coping strategies around eating and inactivity. There are social consequences, of course. People feel discriminated against. They might be bullied at school or in the workplace, and it can leave people feeling socially isolated. And also the consequence of that being this sense of devalued social identity, so feelings of worthlessness and hopelessness. From a healthcare perspective, people are less likely to come to the doctor because their doctor might blame them for the problems that they have on their weight, whether that's valid or not. So people are less likely to come to the clinic and see us. And this is a really important point. I do a lot of work with GPs to really try to increase knowledge around the issues of weight bias and stigma, particularly when starting those conversations with patients that are either presenting because they want to talk about their weight, or they're coming in for other issues. And it might be that that person's obesity is perhaps something really important to address because of the other problems they're coming in. So it's how we start these conversations in a really sort of non-judgmental, equitable way with our patients, where patients feel empowered to have a choice to say no if they don't want to have that conversation, but also feel safe if they do want to have that conversation, that they're not going to be stigmatized and they're not going to be judged. And then also from a societal point of view, bias and stigma just reinforces these stereotypes. and in political circles can lead to policy inaction on things like funding for treatment. So how do we reduce weight stigma? Well, there's no single way. Clarity on definition is key, and I think we're getting there now with the Lancet Commission. Understanding of obesity is a chronic disease process, not choice. We need to distinguish between size and weight and the disease of obesity. So if we understand it as a disease, does it come across as more deserving of treatment? And I think we need to be really pushing that mantra for people living with clinical obesity. Language matters, as I'm sure we all appreciate. And I think as clinicians, it's crucial that we have the right language here and we all talk from the same hymn sheet. People with obesity, not obese people. It's person first. And I do that across the board now. I even with diabetes, I used to say diabetics a lot, and it's people with diabetes. So it matters, and it shows respect. There's some old terminology I still hear. Morbid obesity. It's a word we should just not use. There's other ways to describe obesity, and I think we as clinicians need to hold ourselves above everybody else and make sure we get the language correct. We should start challenge stigma and bias. Certainly in the healthcare setting, I think it's really important. It doesn't need to be adversarial, but I think we need to support clinicians with education where the language is perhaps a bit old school, a bit outdated and biased. And of course, from a treatment perspective, shifting focus away from weight. The whole point of this is health. It's about achieving health, whether that's physical health or it's mental health. That's what the focus should be, not kilograms, not waist circumference. That follows if we get pillars of health sorted. So pillars of health around nutrition, activity, sleep, and mental well-being are really, really key. So that's my focus in my clinic. I talk a lot about those healthy pillars and trying to set smart goals with our patients, things that are achievable, that focus on healthy behaviors. Now, that can be a real challenge. Weight loss is a real challenge. I think there'll be many people in the audience that can attest to this. It's actually very, very difficult. And it's difficult because if we go back to that first slide or third slide, whichever one it was, weight's biologically determined, influenced by the environment in which we live. So just making different choices and just using willpower and motivation alone doesn't always work. And I'm careful with my words there because for some people it does. But actually, if we look at evidence, generally speaking, this is what we tend to see when people follow behavioral change alone through nutrition and activity, that people can lose weight with lots of willpower, lots of motivation, but the body adapts. Again, we've evolved. We're incredible machines. So we have evolved to weight loss and our body will try to bring us back to where we were because your body recognizes it as starvation. And there are adaptive processes that increase hunger hormones, reduce hormones that make us feel full, slow our metabolism, and we tend to put weight back on, and it can be a real, real challenge. So these things here on the right, in terms of interventions, these are just different interventions. The VLED is a very low energy diet. CBT, I think, is cognitive behavioral therapy. BLTD, very low calorie diet, all of those sorts of things. They work for a bit, but often people can find that they start to regain weight. So what do we have available? Now, Alex will talk about surgery. I won't talk about that today, but broadly, we have 3 approaches to weight management, or more specifically, obesity treatment, because that's a bit broader. The cornerstone of management is around behavior change. So it's around trying to create that negative energy balance, calorie restriction, if you like, or calorie deficit to enable people to burn fat, to lose weight. Activity is really key for many reasons. It helps with weight loss, but it is mainly about creating that reduced energy intake to help people to burn fat, to lose weight. So activity, nutrition are really key cornerstones of management when we're trying to achieve weight loss. That can be done, as we looked at on the previous slide, either through behavior change alone, or we have medication that can help, and we have surgical procedures that can help. So those are the three options. Now, really, medication and surgery are both but tools to try and achieve the behavior change. So it's the behavior change. It's the nutrition and activity, sleep and well-being where we achieve the weight loss. So when people talk about weight loss drugs, they're not really weight loss drugs. What they do is they increase, generally speaking, they all work in similar ways to increase the feelings of fullness, what we call satiety, the opposite of hunger. So that's how they work, and they work in different ways. Now, we've got 6 TGA-approved pharmacotherapies in Australia. Some have been around for a long time, and some are relatively recent, just in the last few years. I won't delve too much into them, just in the interest of time, but I think some of our audience will be familiar with some of these. So we've got Ventamin or Duramin, which has been around for a very long time. And it is effective, it does work, but it isn't always tolerated very well, and not everybody responds to it. But it's probably one of the cheaper medicines we have available. Orlistat, that's been around for the best part of 2, almost 3 decades. It works by preventing us from absorbing fat from the gut. But the problem with that, of course, is that it can create some pretty nasty digestive side effects, flatulence, bloating, diarrhea, those sorts of things. So often isn't brilliantly tolerated. And then we have Contrave or naltrexone bupropion. It works quite well, works on the brain to increase feelings of fullness. It tends to work quite well for people that perhaps are a bit more predisposed towards emotional hunger or stress-related eating. But it does work, but not tolerated brilliantly by everybody, and not everybody seems to respond to it. And then we've got the injectables. So these 3 at the top, these are all tablets, and the 3 at the bottom are the injectables that we have available. Liraglutide or Saxenda, it's a daily injectable, but this is going to be unavailable by the end of the year unless somebody starts to make it generically, because Novo Nordisk that make this are phasing it out. And they're phasing it out really because we've got better drugs that are safer and a bit more effective. So I won't talk too much about Saxenda. Wegovy or semaglutide, Manjaro or tirzepatide. So these are kind of flavors of the month, aren't they? These are almost becoming household names. Perhaps just for clarity, Ozempic isn't on there. Some people say, what about Ozempic? Just to be clear, in Australia, Ozempic, although it is semaglutide, the same drug as Wegovy, it's licensed only for diabetes. So we don't use that, and we don't prescribe it for weight loss alone. Wegovy is the treatment that's TGA approved for chronic weight management. And tirzepatide is the other one manufactured by Eli Lilly. And they work very similarly. They are basically synthetic versions of a natural satiety hormone, a hormone that makes us feel full, that we make when we eat food. We make this in our gut, and it basically ramps up the feeling of fullness. It works on the brain to achieve that. And that's how those two work. So they're kind of synthetic versions of these natural satiety hormones that we make, GLP-1. So that's probably something people have heard about. This is the way they work. So they work on the receptor in the brain, the GLP-1 receptor. They turn it on and ramp up that feeling of fullness. So what did it translate into? Generally speaking, 2 or 3 things. People generally will feel fuller with less food. They can go longer between meals without feeling hungry. And they do also alter food preferences. So they often will make, really palatable, high energy, sugary, fatty food, just not so desirable, I suppose. And that's what people tend to report back in terms of how they feel. Now, if I can just move my thing out of the way so I can see this table fully. I was just going to touch on what the pharmacotherapy trials have shown. This is not an exhaustive list, but it really just touches on what we can expect with these medicines. And remember, these are this is trial data. It's not the real world. It's trial data. And these trials report weight loss in different ways. So they're not comparable from this table, but I think it gives us a bit of a flavour of what we expect from these drugs. So all the stat. So this is the
Mark,
medicine.
sorry to interrupt, just briefly. Sure. In interest of time, I wonder if I can give you a 5-minute warning.
Have I got a 5-minute warning?
Yeah, I'm giving it now.
That is the 5-minute warning.
Yeah.
All right, cool.
Thanks.
Then I'm not going to touch too much on this slide because it's a bit boring. But I will flip to this slide and perhaps just touch on the fact that we do see quite a lot of weight loss with medicines like semaglutide or Wegovy and tirzepatide or Mounjaro. So on average in those trials, people are achieving somewhere between 15-20% weight loss over 12 months of treatment. But we were also seeing other benefits, not just weight loss, but seeing improvements in things like blood pressure, glucose levels, inflammatory markers. So this medicine, hang on. Let me just go back a second. So semaglutide also has an indication for the treatment of obesity in people with cardiovascular disease, because it can help in that respect, and Mounjaro also in people with obstructive sleep apnea. Now, I'll flick past that because basically we're running out of time, and I won't bore you with lots of medicines, but just to say that we have about 6 or 7 other molecules in phase 2 trials that we may have access to in the next few years. So the landscape is certainly changing a lot. Now, I wanted to touch on this. So this is an advocacy that we've been working on, the RACGP Obesity Specific Interest Group, with support from other national stakeholder organisations. And this advocacy was on PBS-funded access to pharmacotherapies for people living with obesity. Now, as we've touched on, obesity is a major public health issue in Australia. 1 in 3 adults are living with obesity, and it's around 1 in 4, 1 in 5 children. We've already discussed that the health impacts can be severe, and we know that inequities exist because there is no funding for the pharmaceuticals for obesity in Australia. And if you look at the National Obesity Strategy published 2022, they've set out all sorts of targets about improving equitable access to treatment. And actually, they're not really hitting any of those targets. And that's a problem. So Alex, I'm sure, will, although we do have funding for metabolic bariatric surgery, it's not enough. We need more funding, and I'm sure Alex might touch on that. We have funding for dietitians, exercise physiologists, psychologists, all those sort of supportive services to help people with weight management. It's not enough, but we have literally zero for pharmacotherapies. So that's why this was an important advocacy. We know in the UK, there is publicly funded access to pharmaceuticals. In the USA, there isn't publicly funded access, but you can access it through insurances. But that raises its own inequity issue. But we literally have nothing in Australia. So others are closing the gap. We need to also close this gap. So we were advocating for PBS-funded access to safe and effective pharmacotherapies for people with obesity. And that, our proposal, which we formulated back in June, we submitted to government. We've had conversations with government about how this could be rolled out. And the PBAC, the people who actually decide on this issue as to whether there should be funding or not, are meeting in November. And so we wait with bated breath. They wrote to us just last week, asked for some clarification on some points they've raised. We've responded, and we wait with bated breath to see what we might get. Now, it's clearly justified on 3 grounds that we have access to these treatments. Health impact, because these medicines help people to achieve weight loss, but also improve health. Economic impact, we help people to live healthier lives, more productive lives, and there is good evidence that there is an economic impact, not just more broadly on society, but on things like medical and surgical wait lists, on the healthcare system for people living with health impairments related to obesity. And of course, most importantly, equity. We need equity. So that's the end. And I think I've probably just got a few seconds to spare. So thank you for your time. I'm happy to take any questions, but I will leave that Claire to navigate. I'm not sure if we're going to move straight into Alex's presentation.
Thank you very much, Mark. There is a question in the chat, but I think we will go on to the next conversation, and then we'll open it up for questions at the end. I sense that there's so much information that we're likely to need another session specifically on the questions, but let's see how we get on. So thank you very much, Mark. That was a really thorough overview of the really strong case for the advocacy, and we'll put the link to the some of the posts that you're seeing on LinkedIn about that campaign, and that Alex is also part of that. So thank you very much, Mark, and Alex, we'll come to you now.
Thank you very much, Claire. I'm joining you guys from the lands of the Wurundjeri people of the East Kulin Nation. It's a privilege and a pleasure to live and work and raise my family. Claire, can you just confirm my slides are up for you? Can you see a picture of me? I'm Alex. Like Mark, I'm occasionally paid by companies to talk about medications, mainly, and occasionally surgical equipment. But none of that funding relates to this presentation today. I'm a dad, I'm a doctor, and I'm a general surgeon by training. And I also do metabolic or bariatric surgery, and mostly in the public sector, which makes me a little bit strange as far as metabolic and bariatric surgeons go. And through that, have developed a keen interest in the issues around equity and access. And Claire, to call me someone who is an advocate for lived experience and equity is probably the highest compliment you could pay for me. So I was a bit touched when you said that. Thank you. I really appreciate that. I'm going to quickly touch on an issue. I'm going to use the word obesity, and Mark touched on this as well. When I'm talking about obesity, I'm talking about a chronic, progressive, and relapsing disease. That means something that is causing someone harm at a biological level. I believe that this is characterized by the biology. It's not something we can see with our eyes. It's not something we can measure on a scale or with a measuring tape. It's something that we only get to know if we sit down and take a history and earn the trust of our patients. It's caused by biology, not choice, and Mark, I think, explained that better than I can. But it is not a reflection of a person's lifestyle choices or voluntary behavior, but rather a reflection of their genes and the environment they live in. But I do acknowledge that this word is heavily stigmatized, and just me using it may be harmful to some. And if we need to talk about that afterwards, it's an open invitation. I am open to hearing about any hurt that I cause you by using this word, and I welcome you to contact me, and we can have that conversation, because I think this is the most important voice on my slide.
I think there's a school of thought that bariatric surgery is the intervention of last resort. You know, for people who are on their absolute last legs. Well, why do we have to get to the point of being immobile and despairing with all sorts of other health issues before we get life-changing, life-enhancing, quality-enhancing, life-giving surgery?
This is my friend Tammy, and she's one of the people that I have learnt from. I learned how to do this surgery, and then I really learnt what this surgery was about by listening to those with lived experience. I'm going to quickly cover why metabolic bariatric surgery is the most effective, durable, and cost-effective treatment we have for severe clinical obesity, why that makes it necessary medical treatment, and why I believe our public hospitals are grossly failing in their duty of care by not providing it. And I'm going to sort of suggest that it's probably a bit of time for equity and common sense to enter this space. I want to touch on one of the things. Thank you, Mark, because you've covered this nicely, but I think one of the things I'd add to what Mark said is how we got here. I think it's worth mentioning because there's a lot of really romantic and attractive narratives around the way we used to relate to food, and the shapes and size and health of our body as a result. I think it's worth just remembering that the environment we're in is not one we chose deliberately, and nor was it one that happened by accident. It's happened by step development and dissemination of technological progress. We are better at making our land fertile. We are better at making and storing and transporting and providing food to our homes. But along the same time, over the last 100 years, has been step by step a whole lot of really massive advancements in the way we make money from food. And I've listed a few of them there, but there's many more. And so really we're looking at a situation where food's no longer just fuel for the human body, but it's also fuel for our economy. And that's a complex interaction. And we have come to the point where those two things may not be the healthiest combination for our people as a whole. We have a situation where we have more food than ever, it's more available than ever, and then it's pressed on us in very effective ways to change our behavior. And so when we talk about behavior change, I think it's important to remember that this is not in a vacuum. And in fact, there's far more successful behavior change tools sitting right here, driving what we do day in and day out, that we will struggle to overcome as clinicians or as members of the public. Of course, we don't all get obesity, and Mark touched on this, and it's largely due to vulnerabilities inferred by things that happen to our mother before we're even in the womb, things that happen to the fetus as it's developing, and of course, a very important set of genes we have no control over. And some of those are just general, but some of those are very specific to certain environmental influences. We're figuring this out bit by bit, and it's interesting because, again, it's an example where the lived experience is well ahead of the geneticists. They're teaching us the things that our patients have already known. I was fine until I broke my leg. I was fine until I lost my job, or I got a new job, or I had a baby, or I stopped breastfeeding, or I went through menopause. So certain things happen in our lives that set off these genes. And just like a lot of other diseases, breast cancer and colon cancer, where they're largely genetically determined but don't present until adulthood, this is largely genetically determined but often doesn't present till adulthood. And we've been not very good at picking that up as doctors and the public in the past. And because we see something develop in adulthood, we have, as Mark's very rightly said, blamed that on adult behavior when that's not such a big part. The environmental exposures, as Mark mentioned, are diverse and redundant and everywhere. And it's not all the same things to all the same people, though. We're all vulnerable to different elements. So obesity is a thing that happens when people who are already vulnerable because of factors they largely cannot control are exposed to our modern environment. It's as simple and as complicated as that. The other thing that Mark touched on, and I'll follow up with, is bigness is not the same as badness. And this is why I say severity, the diagnosis and severity of obesity is not something I can measure with a scale or a measuring tape. And this is a very old study now, but it's been repeated again and again and again in the real world. And it's a very crude staging system. It's very easy. Just how much is obesity affecting someone? Is it causing just some risk factors for disease? Is it actually causing a disease that we can diagnose, put a name to, and measure? Or is that disease got to the point where it's starting to cause other organs to fail? Or is it to the point where it's no longer reversible? And those graphs, essentially, the faster the line drops, the more people die. And so those graphs on your screen on the left, we have what happens when you look at people based on how much obesity is affecting them. And the more it affects them, the more they die. Simple as that. Meanwhile, if we look at size and shape, body mass index, it gives us no idea of who's going to live and die. And I still think that who's going to live and die is not a bad measure of health. So I think that makes the point that really it's not about size and shape, but about the biology and the impact on the person that we should really be looking at. And of course, Mark's mentioned that the key to all of this is that once that is set up, it's maintained deliberately by our body, and particularly in control by our brain. And so Mark touched on this, so I'll whip through, but when we diet, when we decrease our intake deliberately, our body adapts to save some calorie. If we still push past, we will lose some weight, but then the body responds powerfully with neurons, with brain-based and hormone-based responses that affect every organ system we know of to maintain weight. And of course, that's not, again, because people have stepped off the diet, as Mark mentioned. It's when people stick on the diet, most of the weight comes back. If they ever stop, no, they don't stay where they are. They go back to where they started. In fact, in a lot of people, their body will prioritize restoration of their fat, prioritize putting the fat back on because that's the energy to survive the famine, and then it replaces the lean mass or the muscle and bone later, so they actually end up heavier than they started. I need to always stop and say I'm not having a go at healthy eating and exercise. They are great and wonderful things, and I drive my patients nuts with them. Things like eating vegetables, shifting from animal to plant-based fats, aerobic exercise, resistance exercise, these are magic. There is no better thing in your life to improve your health, make you live longer, enjoy a better quality of life, reduce your cardiac risk, your mental health gets better, your physical function, all this stuff. But what they don't do when used alone is have a clinically significant impact on this clinical obesity for the vast majority of people. There are a few genetic freaks, but it is around 1 to 2% of our population that will have meaningful clinical response when it comes to clinical obesity from these things alone. They'll still be health promoting, but they won't treat the obesity. Metabolic surgery is different. It doesn't strangle your esophagus and stop food from going down. It doesn't just make food go out the other end. What it does is it changes the body's response to food and its weight control mechanisms. It tinkers with that feedback system and changes the way the body uses energy. And then also, incidentally, has a whole lot of hormonal changes that have other beneficial effects all over the body. What happens from the point of weight is that the set point, the target for the body is reduced. So the body is now running the show. And so people report they stop feeling hungry. The amount of food they need to feel full is less. They feel full for longer before that hunger comes back. They eat less, but they eat less because the body is driving them to eat less, not driving against that. That's how the body decreases intake to cause some weight loss, but it also doesn't shut down. It doesn't say, no, preserve this energy. We're in a time of shortage. People come back and say, oh my gosh, I got more energy than ever. And I say, no, you've got exactly the same energy as always. It's just the first time you've weighed less that your body hasn't been clamping down and telling you not to use that energy. At some point, though, the body will reach that new set point and a lot of normality comes back. Some of that appetite comes back. Some of that food noise, if you like, comes back. And if at that point you try to diet really hard, you'll get all the same issues that you have around dieting. And this is about metabolic surgery. This is exactly the same way the medications work. These are not appetite suppressing medications. After you reach that new set point, some of your appetite comes back. It doesn't mean the medications stop working. They are still working, even though your appetite's come a little bit. Yes, they help you lose weight, but they're not really weight reducing medications. They're set point reducing medications. And therefore, it is normal, healthy, and expected for you to bottom out, gain a little bit of weight, and then carry on at that lower weight. That's normal, healthy, and expected. But of course, this is not actually about weight. Because I don't do weight loss surgery, I do health and life gain surgery. The reason I, as a medical doctor, provide this surgery is because when I do this surgery, people die half as often. And depending on whether or not they have diabetes and other factors or metabolic ill health, in fact, it can reduce death rates by 60, 70, and even 80%. That graph is very small, but essentially the lower the faster that graph rises, the more people that die. The orange line is people who have not had metabolic surgery. The blue line is people who have had metabolic surgery. They just die less. Again, I think that's a good thing I should strive for as a medical doctor. This happens to be the best treatment for type 2 diabetes with obesity. If you have type 2 diabetes and you don't have obesity, then you're stuck with it for life. If you do have type 2 diabetes with obesity, we should be thinking about that as good news, because if we treat the obesity, the type 2 diabetes usually goes away. And if we're quick about it, it will stay away. In people who get metabolic surgery within the first year of getting a diabetes diagnosis, the remission rate's well over 90%. That means stopping all medications, having a normal blood sugar. Most of all, though, again, less people die, particularly of cardiac deaths, but also of cancer-related deaths, and less people end up on dialysis, etc., etc. And so in this setting, it actually costs less to do the operation than not do the operation. It costs less to do the operation than not do the operation. And I think that's important because this is the experience. I drew this with the help of ChatGPT based on my own patients, again, learning from lived experience, the patient's experience of diabetes in the public healthcare system. He described it as a very congested highway to hell, with a predictable step from tablets to injectables to complications over 5 to 10 to 20 years. And there is a way out of this, but in our public hospitals, the road is well and truly closed. It's also the best treatment for metabolic liver disease. And again, I don't think I should have to justify good treatment based on its cost benefits. I think that good treatment should be good treatment regardless of price, but and I still end up having to make these cases. But here I've compared it to hepatitis C eradication. We now have medications that are very good at making hepatitis C go away. In most cases, it will completely resolve the virus. And we provide that free of charge to anyone in Australia because that's really good treatment. Managing a virus and the problems that come from it that causes cancer and liver disease and cirrhosis is a really good thing to do. Metabolic surgery is similarly effective with a similar impact on mortality when it comes to what we used to call fatty liver disease and we now call metabolic associated liver disease. It's actually cheaper than reducing the virus. And I put it to you that there's a big difference here. I remember in my very junior years hearing a talk about this eradication therapy as an intern. I remember someone walking out saying, now we're going to waste all this money on druggies and bogans coming back from Bali with tattoos. The difference here is you could not say that today because we have deliberately put a line in the sand and said, just because you have this virus called hepatitis C doesn't mean you're a second-class citizen. It doesn't mean you don't deserve the dignity and right to care that everyone else does. And good quality care should be provided. The difference here is we have not drawn the same line in the sand about people in larger bodies. We still are playing to the old stereotypes and point blank refusing to do the safe and sensible.
What you see on Facebook pages and the exceptions that get escalated, people do have problems, but the vast majority of us don't have problems and you don't hear about it because we get on living our lives.
This surgery is safe. The death rate is one of the lowest amongst any surgery I can provide as a general surgeon. It is safer for me to do this to someone than take out their gallbladder. It is certainly safer to do this to someone than to leave them without surgery. It is effective, I got excited because it cures things that I was told as a doctor were lifelong diseases that could only be managed. And it does last lifelong in the real world. We're still figuring out medications and what they do in the real world. We have had this and we have 20 and 30 years of data in the real world from this. We don't need to experiment with this. We know it works, but it's not a routine treatment option. And
Alex, I'm so sorry to interrupt, but I'm doing a terrible job as chair. I need to give you a 2-minute warning because we're 3 minutes away from the end. So my apologies, everyone. There's just so much here.
I'll
Thank you,
skip through
Alex.
this and I'll make it very clear. Our public hospitals refuse to provide this. There is funding there from the federal government to provide it, and the public hospitals just say no. And when over 80% of people who want this are women, and the people that need it most are Aboriginal and Torres Strait Islanders, this is discrimination by neglect, and people are dying from the lack of access. This is unique to metabolic and bariatric surgery. We don't do this with any other surgery. And if this was any other genetic and developmental, life-threatening, disabling disease, we would provide it. And we would be angry and furious at our public hospitals when they don't. This shouldn't be a luxury. This shouldn't only be available to those with large amounts of disposable income. And most of all, this shouldn't be something we don't teach our doctors about because this is where they train. And this is why we don't understand larger bodies. And this is why the stigma persists, is because our doctors are ignorant because they train in facilities that don't provide best care.
I think there's a school of thought that bariatric surgery.
So I'll leave this up. The QR code is a chance to sign up, help us. We will teach you how to talk to your hospitals in ways that can be productive. We need your help. We need people to help start knocking the doors down on hospitals and just say this isn't okay. We're engaging with governments in 2 states so far, and we want to engage in yours as well. But we just need more people. We need people with lived experience who can tell their stories, and it's time for some common sense and equity in this space.
Thank you very much, Alex. Now, like I say, I can see some of the comments. This session has been hugely appreciated. And I possibly could have anticipated it, and we could have perhaps set aside, I don't know, 2 to 3 hours for this, but we didn't.
Sorry, Claire.
No. It's the planning. Alex and Mark, can I check in with you because I know you're both taking time away from clinical practice. Do you have, let's say, another 15 minutes for people who are able to stay on, who might have a conversation to be had?
Absolutely. I've knocked off, Claire, so I'm fine.
Sure.
Yeah.
Of course,
Not a
because
problem.
you're at 6:30, aren't you, Alex, where you are? Thank you. So look, thank you so much, Alex. I might just get you to stop sharing,
Oh,
if that's okay. There we go.
yes, gotcha.
And I'm going to open it up to invite questions. Thank you. I have heard both of you talk, and I have been to a lot of things, but I learned a lot from that. And I have to say, a couple of them made me a wee bit teary just hearing you describe so very accurately the harm that is done through weight stigma and bias. And Jackie, you've commented on this before at some of these sessions in terms of the kind of there is that, I think, that poor understanding at the highest levels of decision making, that this is somehow one of those areas that it's okay to not provide treatment for, like you've been both been very clear about, people who want it, people who are accessing expert clinicians who understand the specific topic. So I've given everybody the heads up, so I'm going to open up for questions. And Mark, I know you did respond to this in the chat, but I wonder if you can just talk a little bit, both of you perhaps, about both of the treatment options that you talked there about that sustainability of effect, because I think, many of us in this space have had experiences of trying things and then them not working, or not being sustained. And so I guess, yeah, just interested on any comments on either way, because Alex, I know you and I had a chat at a conference a couple of years ago. It's hard to know, what is the definition of, has this surgery worked, and how do you know in advance whether or not it's going to work for you, whatever that means. So Mark, I'll come to you first about the medications, and then Alex, I'll come to you for the surgery. Mark.
Sure. So Eamon asked a question in the chat about this. Do you have any data on how much weight people typically regain after stopping these weight loss medications? I've responded in the chat, but what we have to look at here is we're not curing anything with treatment, with medication in particular. We can't change genetics, and we can't change the environment, not that quickly. So these medicines are a tool. They work as long as you use the medicine. And although we don't have a great amount of evidence, generally speaking, if people stop these treatments, they will regain their weight. And I think we have to look at it through that lens. And if you think about it, it makes complete sense. If you take treatment away from a person living with diabetes, or a person living with a cardiovascular disease, or living with cancer, the disease comes back. And it's no different with obesity. So again, there can be this perception that these treatments are used to, kickstart weight loss, and then somehow willpower and motivation will maintain it long term. And again, we just fall into this sort of these old narratives where we think obesity is a choice. It's not. They work as long as we use them. We've got good data about that, particularly with tirzepatide, used over a long period of time, over I think 3 or 4 years. The weight loss is durable, but you stop the treatment and your weight's going to come back on. So that's the problem with medication. It's expensive, it's not funded, and you have to pay for it for a long period of time. Whereas with surgery, one operation, one cost.
Thanks, Mark. Alex.
Yeah, I think that is a consideration, and I think what that is now allowing is it's an exciting space for us, because one of the things we've not been able to do is that there are many circumstances where stepping into surgery is really nerve-wracking. You're not quite sure what's on the other side, and that's from the lived experience point of view. This is a whole alien thing, and some people are lucky enough to have friends and family close to them that have been on that journey and they get some insight, but there's people that don't. There are other conditions where we're not quite sure how these conditions are going to interact with the surgery. And so one of the wonderful things we're able to do now that we could never do before is, because these work in such a similar way, that I can start an effective medication. Let's see what happens on the other side. And I'm finding this really useful in teenagers and young people as they're still developing, because at the end of the day, if the interaction is not as we want it, well, we've got something we can take away. In most cases, though, we say, right, well, this is what life is like on the other side. We're okay. And then we can proceed to surgery with that confidence that that we didn't have before. So that's a really cool way to use these medications. The other thing is that there are at the extreme end, and this is very rare, but we have a group of people for whom obesity or other diseases have had such a profound impact on their ability to breathe and move and for their heart to function that surgery is actually legitimately dangerous. You know, the sort of thing where they're waking up in ICU and slowly coming off ventilators, all this sort of thing. And so the medications at our hospital, fingers crossed, soon we will have access to a limited amount of funding for short-term use to use these medications in people to improve their heart and lung function enough that then we can safely go on with surgery as the more permanent solution. And so that's so there's so much excitement in this space. And then as a cancer doctor, I do esophageal and gastric cancer surgery. The idea of treating such an important disease as obesity with a single agent only is so different to in cancer care, where we all sit down and discuss every patient and say, right, what's the combination of radiation and chemotherapy and surgery that's going to be the best for this patient? And I think that's where we're going to be in 20 years' time. And I can't wait. We're going to, and it's, but the reality is getting there. In terms of the longevity of surgery, one of the issues we have is there's so much focus on the weight. And what we often find is if we look at the clinical issues, does the diabetes stay away, or is the diabetes better controlled? Can people walk better, move better, play with their kids better, all those sorts of things? They persist. What we see in all the long-term studies is people go back to what we call baseline weight trajectory. So one of the things to point out in general is that over the life course from about 20 to about 70, we put on weight at about 1 to 2% per year. In people with obesity, that trajectory is a bit steeper. But that's normal. That's what normally happens. And so one of the things that drives me absolutely bonkers crazy is I'll meet someone who's had 10 years of stable weight and people think they're a failure, even though that is actually the sign of they're fighting biology successfully and they're winning. Even worse, I'll have people that are 5 or 10% below their starting weight. You know, I've shown you all the diagrams of what's supposed to happen. And again, that person's labeled as a failure. And it's another reason why glancing at someone and measuring them is not a true appreciation of what's going on with them. And so often I'm sitting there going, no, you're a success. We can build on this and we can do other things. But I'm looking at someone who is, you know, a top 1% achiever in terms of weight loss based on what we know from science, and they still think they're a failure. But at the end of that journey, what we see is people will return to their baseline weight trajectory. And I suspect that's what we're going to see in the real world with medications. And anecdotally, that is what we're seeing. That's still okay, because what you've done is you've taken someone that was doing this and they're doing this. And what we know is, regardless of all of this, the percentage of weight loss maintained over time is the best indicator of the clinical impact. So if they're 10% below, that's when we start to see the real magic. Up at around 15 or 20% below where you started, then we're often seeing that diabetes going away, avoiding hip replacement, knee replacement, you know, the real game-changing things. And again, part of go back to the stigma thing, the problem with that is if you're 20% below your starting weight and your starting weight was 200 kilograms, and you weigh 160 kilograms, people are going to look at you a certain way. Meanwhile, if you use that same 20%, which will take the same amount of effort and go from 100 to 80 kilos, there'll be a lot of backslapping and celebrations that the person at 160 kilos richly deserves, but will not get because of this misunderstanding. And so there's a lot goes into that. But what we find is that, we reach our lowest weight. I don't think lowest weight is healthiest weight. I think you're supposed to regain a little and go on. I'm always a bit nervous when I see someone at their very lowest weight after surgery. And then you will put on that 1 or 2% per year. And yes, we can manipulate that with medications if we need to, but in a lot of people, for clinical reasons, we don't need to. We can accept that because we've got function back, we've got health back. And so it's not about less, you know, weighing less is not always better in all circumstances.
Thank you. And look, I think the difference I'm seeing. So last week was the Australian New Zealand Obesity Society conference, and a couple of us on this call were there. And I think what I saw was a really heartening shift that's been a while coming, and using the same language that you guys are using, that this isn't about size or body shape, it's about the impacts of health. And there was a post just on LinkedIn that I had seen just earlier that named that really well, I think, because I think it can be difficult in this space. So I guess just in the last 5 minutes, as in the extra 10 minutes that we've had, in the last 5 minutes, I guess I'm interested in your take on like the advocacy steps from here. So obviously Health Consumers Council, we're a health advocacy organisation, we're a charity, we stand up for health consumer rights. We are the hosts of the Well Collaborative. And personally, I think many people know I'm also involved in the Weight Issues Network, as are a couple of other people on the call. Is what are they, if someone were inclined to be part of the campaigns that you've outlined, and while they're two different campaigns, they're both obviously focused on addressing that equity of access. What message might you have to people who might want to be involved in that? Mark, I'll start with you and then come to Alex.
Thanks, Claire. So this is a really important issue, and I think as much as clinicians advocate, we just don't carry that power. We need people of lived experience to advocate. And I think you only have to look at what's happened over the last year or two. Look at the changes that have occurred on the Medicare benefit schedule and the pharmacy benefit scheme for women relating to women's health, access to contraceptive pills, access to menopause, health assessments, PBS funding for all of those types of treatments. So they've advocated brilliantly. People from all walks of life, so clinicians, people of lived experience. I know 1 in 2 people is a woman, and therefore there's a lot of people. But there's a lot of people living with obesity, 1/3 of adult Australians. So, we as clinicians need to empower people of lived experience to really stand up and ask for support. How do you do that? Look, there's different avenues that you can take. You can, one-to-one, contact your local MP and say, there's no access to treatment. I'm living with a chronic disease. What are you doing about that? Because they are elected members of Parliament. They're there to represent you. You can join an advocacy program like Alex's. You can join the Weight Issues Network, the Health Consumers Council, and join a body of people, because those voices are powerful. But we need those voices in Parliament. We need people of lived experience to advocate. Otherwise, the government, policymakers can choose to listen to us or not. But if we don't have the people that are affected by this disease standing up and asking, demanding for the treatment they deserve, then we're disempowered as clinicians.
Thank you, Mark. Alex, anything to add?
I'm going to quickly share again and just whip through. So this is sort of specifically around the surgery aspect. I agree 100% with everything Mark said. We do actually have funding available for hospitals that choose to provide this surgery, but what we're lacking from the federal government is any direction, promotion, or pressure on the states or hospitals to do that. So that's really the message to the feds: is you're already doing the activity-based funding, but it's time for you to push the states to deliver on the funding that you've made available. And really that's what we need from them. The states actually have the surgical capacity for this, that they're just using it for other things, which are also important. But I think you can, to me, it's not about how many people actually get the surgery. I think that's not the point we need to make. It's about how many places it's available. Ultimately, it's up to people to make their own decisions about the treatment they need, but the discrimination here is in blocking access to a specific and very specifically in a way that we would never get away with. I'm not even allowed to cap my numbers for reflux surgery, right? Yet we cap this. There is nothing else I do where a hospital would ever say to me as a practicing clinician, no, you can't do that evidence-based treatment. So it's very specific, and we need to call them out on it. Really, the main message, though, is that the ultimate decision comes down to at the health service level. So at Queensland, that's one whole health service. In New South Wales, it's a bunch of districts. Here in Victoria, it's kind of small hospital networks. But whichever level, ultimately, that's the decision making. And so you are allowed to write letters to the CEO and the board of your hospital saying what they should do for their community. They are there to serve you. They are supposed to be responsive to your community's healthcare needs. But mostly we need to tell people that they are allowed to demand this in the same way as they would demand any other treatment. They're allowed to step up and say, this is the best treatment for me. I'm allowed it. And the other thing is we need to be aware that there's a whole lot of people out there that don't need this surgery and don't want this surgery, and that's okay. But we also need to help educate them that just because they don't need it doesn't mean someone else doesn't. In much the same way as just because I don't need cancer surgery doesn't mean I don't support someone else having it. And so that needs to be the message. And we are very happy to be contacted and to help with that. We can help you make the connections you need. We can support you. We can provide you with information or data or ideas on ways to express things, any of the slides that I've had today or any others to do that. But ultimately the message, and I've hopefully deliberately turned this down on this time, but that this is effective, durable, and cost effective, and it is necessary. And that's the thing that we need to keep saying over and over again. It is necessary. And it is necessary in every moderate-sized regional hospital and above. This doesn't need to be done in fancy ivory tower hospitals like mine. It can and is done really effectively closer to people's homes in regional hospitals, out of metropolitan hospitals, and yes, in the tertiary centres, but it needs to be there and available for those that need it. And get in touch. I think that I have the QR code there somewhere, but we that QR code will just allow to give you names. If you're really quick, then we've got a webinar in about an hour where we're going to start talking about things in depth, but that's a bit too quick off the mark.
Look, thank you to you both for taking time away, like I say, from your clinical commitments and your life commitments, because in this day and age, I'm going to unspotlight us so that we can go back to everybody, be seeing everybody. I guess I just wanted to say, we obviously, I underestimated, I feel like, the time we might need. And so at Health Consumers Council, so we've got, like Tanya said, so Tanya has shared a link to an evaluation form for today's session. So if you can take a moment, we're a learning team. She's just shared it again. Thanks, Tanya. And in that, we've put a couple of things. One is, would you like to be involved in campaigning on this going forward? And the second one is, do you have any questions? There's a question there about your slides. Mark, Alex, I'm guessing that you're okay for your slides to be shared. Thank you. I guess the other thing I would add is that in Western Australia, we are, as I understand it, one of the few states and territories that doesn't yet have a public multidisciplinary weight management clinic for adults. I heard at the Obesity Society conference about many of the other states and the difference that they are making to people's lives. But also, let's face it, governments are also quite focused at the moment on the pressure on hospitals. And I saw some great research come out of South Australia that showed the impact that increased weight has on extended length of stay and extended complications. And again, we're going to be looking at that. Like you, Alex, we shouldn't have to be making the case because of the impact on resources, but we know that it can help in terms of helping to make that case. So we'll be looking at that too. We do have another Connect, Share, Collaborate session before the end of the year. We haven't got a date yet. I think, though, for me, having had a fire lit under me again at the Obesity Society conference about and reiterated by today's work in terms of how we can just help to use the collective energy that there is through the work that we do at Health Consumers Council and the contact that we have with people right across the state is how we can just help to bring some attention to this. All caveated with what has been made very clear by both Alex and Mark, that this is not about an expectation that anyone will be seeking any treatment at all, but rather that if you do and you've worked with clinicians who you trust and are able to make an informed decision, that it be available to everyone. I hope you'll join me all in doing the traditional Zoom thank you, which obviously we got very used to in COVID times. But thank you very much to you both for your, like I say, your commitment and your passion for this work and for improving equity of access. And many of you on the call, on the Zoom, I know share that too. For now, thank you very much, Mark. Thank you, Alex.
Thank you.
Thanks, everyone.
Thank you so much. Thank you very
Thanks
much.
again. Bye.